Hi, my name's Abigail Bennett. I am a master's student in the University of New England, Applied Nutrition with a Dietetics Focus program. This is for APN 785, and today I will be presenting patient SM. So she is 57 years old. She is 66 inches tall, 107.6 pounds, putting her BMI at 17.36, putting her in the underweight category. Her usual body weight is 60.1 kilograms, and her ideal body weight is 59.1. And then the weight changes in the last 6 months is negative 6.5%. And then her chief complaint on current admission is cancer pain. So her primary diagnoses include hypomagnesemia, hypocalcemia, history of fallopian tube cancer, history of colostomy with chronic colonic stenosis, and then bilateral DVTs and anemia. Her secondary diagnoses include fallopian tube adenocarcinoma, chronic strictured colostomy with moderate stenosis at hepatic flexure, immunotherapy-mediated colitis, colonic stenosis, BRCA positive, and then DVT in 2022. And then her past hospital admissions with Sarasota Memorial was in October of 24, and that is when she was actually her usual body weight the last time she was. So she was 60.1 kilograms then, which puts her on an 18.8% weight loss in 14 months. And then in January of 2025, she was 52.2 kilograms. So from January, she's now at a 6.5% weight loss since then in 6 months. So most of her labs were actually pretty good. The only ones that were out of range was her hematocrit and her hemoglobin, which were both low, which is typical with somebody with anemia. So we did note that. And then her medications. So she's currently taking cholestyramine for her colonic stenosis for 7 days, enoxaparin for her DVT for 5 days, pantoprazole, which reduces the gastric acid for those with colitis. It's also especially helpful for those taking steroids. She takes that once daily as needed. Prednisone for her colitis for 8 weeks. She takes pregabalin for chronic pain daily, and spironolactone, which helps with her fluid retention, and that's a daily medication as well. So a little bit about her social history. She is a teacher. She is married with 3 adult kids. One of her kids lives in Venice as well. And then she does have a graduate schooling education. And then a little bit about her lifestyle. So she doesn't drink anymore. She used to drink on weekends, but quit in her 40s. No tobacco use, no exercising, and sleeps 4 to 5 hours a night due to. So when I assessed this patient for malnutrition using the Nutrition Focused Physical Exam, I did find that she is meeting less than 75% of her estimated energy needs for greater than a month. She's had a negative 6.5% weight loss in 6 months. That just didn't put her in either a moderate or severe category. She also has some mild subcutaneous fat loss, some mild muscle mass loss. She does have fluid accumulation, and then no reduced grip strength. So she is meeting 4 of those categories. So the problems that the dietitian is responsible for treating is the inadequate energy intake related to the cancer pain. I did her nutrition assessment based on her admit weight of 48.8 kilograms and her BMI that was 17.36. So I did increase her energy needs to 30 to 35 kcals per kilogram just with that weight loss and the cancer. And then I upped her protein to 1.5 to 2 grams of protein per kilogram, and then 30 to 35 milliliters per kilogram of fluid a day. So just for the purpose of not being in this shot, I kind of got out of the way for it real fast. But for her PES, I did moderate malnutrition in the context of chronic illness related to physiological causes increasing nutrient needs due to illness or condition, physiological causes resulting in anorexia or diminished intake, an alteration in gastrointestinal tract structure and or function, and I listed the reasons, which would be the cancer, chronic pain, colostomy with chronic stenosis, and colitis, as evidenced by a mild muscle wasting, mild fat losses, meeting less than 75% of her estimated nutrient needs for greater than a month, and the edema. So for her interventions, I educated her on pain medication prior to meals just to help alleviate that pain and take that factor a little bit out of the picture when she's trying to eat. And then I educated the patient on small, frequent meals, high calorie and high protein foods, replacing her meals with meal replacement drinks if eating is too difficult, staying hydrated, other strategies which could just be mixing in a protein shake with her cereal instead of regular milk. So we went over a couple of those things. And then we discussed goal setting with the patient to meet her daily meals and snacks. So she's going to keep up with meeting 3 meals and 2 snacks, even if it's small to start with, but trying to get in those main components every day. And then I did refer her to an outpatient oncology dietitian for SMH, and that was her patient request. So we went ahead and honored that. And then I did add the Kate Farms twice a day. That adds 910 calories, 40 grams of protein. And that's for her hospital stay. And then if she wants to continue those at home, that's completely up to her. I would prefer her to, especially while she's not meeting her nutrient needs with her oral intake. And then the nutrition monitoring and evaluation. So I'm going to monitor her PO intakes. I'm going to monitor her GI function, the edema. I'm going to monitor her hematocrit and hemoglobin labs just to make sure that anemia levels out. Monitor her supplement intake, and then monitor the outpatient dietitian adherence. And that's all.